Now we are here for a TAVR case. Patient is 74-year male, diabetic, and history of subdural hematoma. And patient was having severe calcific aortic stenosis. He was having history of the dyspnea on exertion and the fatigability since couple of months. So he was diagnosed severe calcific AS with mild AR, mild MR, and creatinine was little bit on the higher side. So we evaluated as a heart team with a CTVS surgeon, and we considered this patient for the TAVI considering the high surgical risk. So if you see the echo is severe calcific aortic stenosis, velocity is 3.9, peak gradient is 42, mild MR, mild AR, and normal LV function. If you see the ECG is having a normal sinus rhythm. There is no underlying bundle branch block, so we are not predicting per se as a conduction system disturbance considering this ECG. Again, we will plan to minimize this risk as well. If you see the aortic root analysis, the valve is actually bicuspid type A. There is L and RCC and the LCC fusion, and the single raphe. It is a type 1A bicuspid aortic valve. Severe annular calcification, and the calcification again extending from LVOT to NCC, and again NCC, RCC and the LCC. So it is a basically a very high risk for the complication. And again LVOT, this is basically smaller than the annulus, and there is a again a mild calcium in the this arch of aorta, and again it is a horizontal aorta. So if you see the what is the transcatheter valve selection, we can have two kind of valve. One is balloon expandable, and second one is the self expandable valve. So considering this anatomy and the annular parameters, we can choose balloon expandable valve, possibly 29 millimeter or even smaller, and balloon self expandable valve. And self expandable valve, according to parameter, we will choose like 34 millimeter valve. So in this particular case, considering the high calcification in the annulus, as well as this is extending into the LVOT and the chunk of calcium in the calcium nodule in the annulus, we are going to proceed with this new valve of Medtronics, that is the Evolute FX valve. So we will tell you what is the good thing about this valve. So in this case, we have chosen the 34 millimeter Evolute FX valve for this case. So if you see the LVOT, again LVOT is smaller than the annulus, and we have actually the tapered anatomy. So there is less chances of the valve embolization considering this anatomy. So again, if you see the ICD at the 4, 6 and 8 millimeters, all the parameters of the ICD are more than annulus. So again, if ICD is more than annulus, it is mean that the valve size we will consider according to annulus. And again, supraannular, the ICD is fairly good, and we are having the less chances of the complication in terms of the injury. So again, if you see the SOV's diameter, again it is everywhere from LCC and CC and RCC, it is more than the annulus. So again, we will predicting that our valve leaflet will sit comfortably in the sinuses, and there is a less chances of the coronary obstruction in this particular case. Although we have seen in this case, if you see, there is a chunk of calcium in between the RCC and the NCC. Again, this is a point of concern. So we will be very careful during the dilatation with the balloon, because the chances of any complication is high. So at this point, we should be careful. It might be pose some problem in the valve crossing because of the calcium. Let us see how it goes on.
Snare should be 25 millimeter.
So again, if you see the coronary heights are fair, and both the coronaries are good. So there is a very little chances of the coronary obstruction in this case. So we will not take any kind of the coronary protection. Simultaneously, if you see the STJ is more than annulus, so we are very pretty much safe that our stent frame will not going to injure the STJ, because the STJ is 37.5 and it is very much more than the annular size. If you see the aorta and the angle of the aorta, it is the angle is like 78 degree. So the aorta is basically the horizontal aorta. So again, it is a problem itself. to cross the device and the wire from the horizontal aorta. So again, we are predicting some challenges over here. Let us see how we will do this case. The valve crossing planning is like we will put the pigtail into the right coronary cusp, and the inner border of the pigtail will be the marker of the possible aortic root aperture. We will try to focus on this area for the valve crossing. Again, the calcium quantification, calcium is very much high and it is everywhere, so we will be very careful regarding the pre-dilatation and the valve delivery. Again, the calcium distribution pattern, if you can see that this calcium is actually extending into the LVOT, it is 6.6 millimeter below from the annulus, and again it is from the NCC side, so we can have any kind of the this conduction system disturbance. So we will try to prevent this complication as much as we can, but patient can need pacemaker after the procedure. So these are the procedural angles, and we will try to cross the wire in the coplanar view. Then we will deploy the valve in the cuspal overlap view, and this is the procedural angle. Iliofemoral analysis, iliac arteries and the femoral arteries are very much good, so we are not going to face any problem at this point. And again, there are 4 possible procedural challenges, that is valve crossing, but we can basically have a Landerquist wire as a buddy wire or snare or balloon assisted technique to troubleshoot this problem. Again, there is a high chances of the annular rupture because of the nodular calcium. It is 12 millimeter inside the annulus. So we will basically avoid the aggressive pre-dilatation and aggressive post-dilatation. And again, we have chosen this evolute effects because of this problem itself. Because in these particular cases, balloon expandable valve can be a more aggressive approach rather than the self-expandable valve. So again, we have taken the most safer device as of now. So again, I have discussed the conduction system disturbances because of the calcium is extending into the LVOT. So we will try to implant the valve as high as possible. And again, we have thing regarding the sentinel protection device in this particular case because of the high calcium. But as we all know that the protected TAVR trial that is published in 2022, it has shown there is no remarkable benefit when we use the sentinel device. But again, we analyze the arteries. But again, this common carotid artery is very tortuous, and sentinel is not going to fit, and it is not the appropriate case for the sentinel device. So we are not going to use the sentinel device in this particular case. So again, we will do this case in the cautious sedation. So this is the basically procedural challenges, and this is the backup plan. So again, we are going to do the case, and we will discuss in between that. Thank you. Dr. Amit Chaurasia is a very renowned figure of the India, and he needs no introduction, I know, and he is having with me for this particular case. I would like to discuss with Dr. Amit that how he feel in this case and what is the procedural plan, boss. Please tell.
So we all agree that TAVR would be a better choice for this patient, 75 years old, heavily calcified anatomy, once subdural hematoma, already a high risk for second surgical procedure. Now, if you look at the CT of this patient, we all agree that the annulus is more than 26 millimeter, LVOT more than 26 millimeter, and the supraannular design means measurement are also equivalent to or more than that. That means it's a tubular kind of anatomy. If it is a tubular kind of anatomy, then we need to size the valve as we size tricuspid valves. So anything above 26, we are going to take a 34 millimeter valve. This is a very hostile anatomy. If you see, we have a huge chunk of calcium on the annulus, as well as that chunk of calcium runs into the LVOT. So balloon expandable valve is a big no-no in this case because of the amount of calcium as well as the calcium running into the LVOT. The reason is if you expand a balloon, this calcium might just crack and cause an annular rupture. Now, if you see, Dr. Gautam has already discussed that this valve less chance of embolization. Though we are going to use a 34 millimeter valve, this is a self-expandable valve, so very less chance of annular rupture. We are not going to be very aggressive in pre-dilatation. The minimum diameter is 23, so we are just going to take 22 millimeter balloon in this case. So these are about the valves. If you see the coronary height is good, STJ is height is good, sinus of vessel by diameter is very good, so the chance of coronary occlusion is not there. But this is a very horizontal aorta. So if you see the angle is 78 degree, and 78 degree makes almost a very horizontal. So crossing the valve can be difficult for two reasons. One is it's a bicuspid aortic valve. The second is it's a very horizontal aorta. Predictably, if we are going to use a catheter, we'll start with a AL1 catheter, but I suppose we may have to jump to JR or a multipurpose catheter to cross this valve. Now, if you see below in the abdominal aorta, there is a turn in the abdominal aorta. So there is a small tortuosity in the abdominal aorta. And if you ask me, preferably in this kind of cases, I would prefer to intubate the patient because for a single reason. When you put a stiff wire, this aorta is going to straighten up. And as it straightens up, the patients usually have severe pain. Now, we are going to use a FX in this case. FX, since it has a single spine, it is going to be a very trackable valve. But since it is a 70 degree, we are also going to take a precaution by putting just a snare in the abdominal aorta, so that in case we are not able to track the valve, we'll use the snare assisted technique to just enter the valve. We are going to position this valve at 3 to 5 millimeter in the LVOT, so that we negate the chance of any kind of pacemaker. Dr. Gautam has already told that this patient doesn't have any uh, risk, ECG risk for pacemaker, particularly the patient doesn't have any RBBB, which is a very high risk. But you should also keep in mind that there is a huge chunk of calcium, and the calcium runs into the LVOT, particularly if the calcium runs at the site of NCC, RCC, then the chance of pacemaker is very, very high. So though we predict a very less chance of pacemaker in this case, but still we cannot negate it completely. So what we are going to do is we are going to take the left puncture. We are going to put the snare from the left puncture, the pigtail also from the left puncture. We got a temporary pacemaker from the IJV in this case, and from the right side we are going to take the valve. Let's. I think we'll
Let's
start
see.
the case, and this is all
We
about the
will
case.
start the case. पैर हटाना बस,
शुरू करना।
1 मिनट पैर हटाना बस आप।
Wait. स्नेर बोलो। Let me handle this.
I'm on floor, just go। ठीक है। फ्लश।
Okay. Pressing stop. It's at 140.
Yes, sir. Patient.
Okay, pacing off.
Pacing off, sir.
Acha.
Hmm.
जाओ जाओ. Go to slightly. हाँ चलो जाओ. हाँ,
Sir, 180.
Fluid, fluid.
Pacing off.
Pacing off.
Yes, sir. Back. Is it photon in Jana?
Chalo. So basically this is the one of the toughest case we have done recently with the evolute FX valve. We wisely chosen this FX valve because of this complex anatomy. The challenges was that I already discussed that this is a bicuspid type 1 and LNR fusion, and again the problem was that there was a calcification right on the raphe. So there was lot of problem in that case, right from the beginning to the valve crossing and to the balloon pre-dilatation, and again the crossability of the valve, and again the possibility of the post-dilatation. So in all these things there is a high chances of the annular rupture, conduction disturbances, as well as the PVL. So these are all three issues we have to basically address right from the beginning. So we took the right femoral access. Can you show me the sheath insertion? So if you see this, we have taken the right femoral access and we put the sheath 18F sheath via the right femoral access. We put the pacemaker from the jugular access, and again prophylactically we have taken this. Can you focus on this? We have taken the two access on the left femoral artery. One is for the snare. We were in the appreciation that the valve will not cross, we will do it by the snare only. So again this was our backup plan. So next please. So we took the pigtail catheter and we placed the pigtail catheter into the non-coronary cusp, as you can appreciate on this. So again, this was the actually we put the pigtail catheter into the non-coronary cusp, and then we take the AL1 catheter and we try to cross from the lateral border of the pigtail catheter. That was again the plan. So again, as per prediction, it was basically a tough crossing. We took the Teflon wire, then again we took exchange with the Terimo exchange length wire. Then we again took the AL2 catheter. Then again we have tried with the. Can you see? Can you move it? Next, please. Next. We took the AL catheter and then again we took the JR catheter, but again all these tricks didn't work. But finally we again took the AL1 catheter and we crossed the this valve aperture with the AL1 catheter and the Teflon straight tip, as you can appreciate in this scene. Next, please. So after this we took the pigtail, and you can appreciate that this wire is nicely seated on the LV apex. We took the pigtail. Next please. We took the pigtail, we exchanged the pigtail and with the Landerquist wire. Please next. Next please. Next. So you can next please. So you can see the Landerquist wire, because the Landerquist wire was the wire that was able to cross, because when we pushed the this pigtail into the valve, it was a very horizontal aorta. We didn't have any support, so we struggle a lot to cross the pigtail from the valve aperture. So again we took the Landerquist wire and we exchanged the pigtail. Next please. So the plan was to post dilate with the 22 millimeter balloon. So we post dilate very carefully, very slowly with the post dilated with pre-dilatation of 22 mm balloon. Next please. So as you can appreciate, there is a pre-dilatation with the 22 millimeter balloon. Next. After this we checked the echo and there was no any annular rupture or any kind of the AR that is developed, so we are safe at this point. Now it was the time to exchange our delivery catheter with the 18F sheath. This is our delivery catheter, and this is the trackability. Please next. So again, the Evolute FX is a very beautiful device in terms of the tracking, and we didn't have any problem with the valve tracking and the valve crossing. So the idea was to take the snare was actually dropped, because we don't feel any problem in the valve tracking and the valve crossing. Next please. So again you can appreciate this is the valve crossing. We are going to cross the valve. So this was the you can appreciate that the how easily we can basically cross the valve because of the good pre-dilatation. So this is the valve positioning, and the idea is that to you can appreciate the black marker should be at the level of the base of the pigtail. So please show next. So this you can appreciate that the please. So next. Yes. So this is the you can appreciate that the black marker seated at the base of the pigtail. This is the marker of the Evolute FX. Please next. So at this point of time we begin the opening of the Evolute FX, and very slow, and at this point we basically next please. So at this point next back jao. This point the valve was not disconnected, and at this point we check the echo, and echo shows the good positioning of the valve, and the gradients were good. So we proceeded again with the disconnection of the valve, and then we release the valve at this point. So you can appreciate there is the release of the valve at this point, and there was some conduction disturbances actually CHB developed at this point of time, as you can appreciate in the monitor. So again we saw the echo, and echo was good. There was no pericardial effusion, and all the parameters were good. Dr. Adarsh, can you show the echo? We would like to see the echo. So as you can see, there is a beautiful opening of the valve. Put the color please. Yes. There is a trivial PVL you can see, but again I do not think it is an area of concern for us. And again you can appreciate the gradient. Can you measure the gradient please? So as you can appreciate that the mean gradient is like 10. So we are pretty happy with the result, and there is the positioning of the valve, and I hope the trivial PR will this paravalvular leak will subside over the period of the time. As you can appreciate in the ECG, there is a CHB, intermittent CHB is there, but we are thinking to put the pacemaker considering the anatomy and the calcification characteristic. We are very pretty sure that this calcium will impinge the impinge the conduction system. So we are going to implant the pacemaker just for the safety of the patient. So this is all about the procedure. Again, if you summarize it, it is a very tough, complex TAVI case that we have done today with the Evolute FX valve, and lot of learning for us. So I'm very thankful to all my staff, my technician, my colleagues, Dr. Adesh, Dr. Krishna, and again Dr. Amit Chaurasia. He was helpful and a lot of learning to work with him, and we have done the successful case. Thank you. Thanks.